Hello guys, good evening. So today we are going to discuss today a few questions on endocrinology. Right? Let's start with the first question. So a 45-year-old woman, known case of type 1 diabetes mellitus, rheumatoid arthritis, presents with 6 months history of fatigue, weight gain, dry skin, constipation, and a neck swelling. A thyroid ultrasound shows heterogeneous echo texture with increased vascularity. And what are her laboratory tests reveal? A TSH of 12, so it is elevated, and a free T4 of zero point 0.8 nanogram per deciliter, it is reduced, right? So high TSH and low T4 is suggestive of hypothyroidism. And what does the ultrasound tells you? It shows heterogeneous echo texture with increased vascularity, suggestive of thyroiditis. So what would be the most likely diagnosis for the patient? So the most likely diagnosis would be Hashimoto's thyroiditis, right? So what are the risk factors for developing this condition? So the common risk factors for developing this condition are the female sex, older age, and family or personal history of any other autoimmune diseases in the patient, pregnancy, postpartum, and sometimes if there is an increased level of iodine intake suddenly, that can also result in Hashimoto's thyroiditis. And what are the possible complications of this condition? Third question is, what are the possible complications? So the possible complications would be dyslipidemia, infertility, depression, and a medical emergency because of hypothyroidism that can arise is myxedema coma. And a specific complication of Hashimoto's thyroiditis is Hashimoto's encephalopathy, right? So, since it is a thyroidite, a chronic inflammation of the thyroid gland can result in non-Hodgkin's type of thyroid lymphoma, right? So these are the possible complications of this condition. And what is the first line treatment? So the first line treatment would be obviously thyroxine supplementation. And how should be the treatment dose be adjusted and monitored? So there are two ways. One is that you can directly start away with the replacement dose of 1.6 microgram per kg dose, or if the patient is elderly or if the patient is having heart disease, you may start the dose at a lower levels of 25 to 50, right? And you can gradually taper the dose according to the TSH level by doing frequent TSH monitoring at a frequency of 4 to 6 weeks. And if the TSH has normalized and the patient is asymptomatic further, then you can increase the duration in between the monitoring, right? You can check every 6 to 12 months later. So these are the answer for the first question. Now we move on to the next question. A 25-year-old woman presents with palpitations, weight loss, eye discomfort, and dryness. On physical examination, she has a diffuse goiter, tachycardia, and exophthalmos. A blood test reveals free T4 of 15 nanograms, obviously elevated, and TSH of 0.1. It is less than 0.4 and it is suppressed. So high free T4 and low TSH. And what do you see in the thyroid scan? You can see increased iodine uptake in both the lobes of thyroid diffusely. So the probable diagnosis would be hyperthyroidism due to Graves' disease, right? The Graves' disease is the most common cause of hyperthyroidism here. So it is the most likely diagnosis. And what is the name of the antibody that causes this condition? If you remember the pathophysiology, the thyroid stimulating antibodies or thyrotropin receptor antibodies are the antibodies that are implicated in the pathogenesis of Graves' disease. What they'll do, they'll act on the thyroid TSH receptors on the thyroid gland, and they will keep on activating them, thereby producing more and more thyroid hormone. So what are the potential complications of this condition, especially related to the eyes? So especially related to eyes, what are the what is the complication that you find? It is Graves' ophthalmopathy, right? And other potential complications other than the eye orbitopathy, we have the cardiac arrhythmias like atrial fibrillation, and the medical emergency associated with the thyrotoxicosis is thyroid storm, and the patient can develop osteoporosis, right? So these are some of the potential complications. In the exam, the examiner usually specifies the number of complications that you may have to write, right? He may mention 2 or 3 or 4. So what are the main treatment options for this condition? So this is a case of hyperthyroidism. What will you give them? You will have to give the patient some. The medical management would be to give the antithyroid drugs like methimazole or propylpiouracil, and or else you can also give radioactive iodine, or you can also do the thyroidectomy, right? The problem with the, okay, what is the next question? What is the expected outcome of this condition after treatment? So this may not be the common question that is given in the exam, but still So the common outcome is if you give the medical treatment, what will happen? As soon as you stop the medical treatment, there is high chance of recurrence in up to 40 to 50%, right? And the radio iodine uptake and the thyroidectomy will completely cure the disease. But if you completely remove the thyroid, what will happen? You may have to supplement the patient with lifelong thyroxine supplementation, right? So these are the answers for the second question. Now let's move on to the third question. A 45-year-old presented to OPD and he what is his complaint? His only complaint is his old ring is not fitting his finger, right? And the usual another common kind of presentation that is given is the previous pair of shoes that the patient uses is not fitting now. Okay, this kind of presentation can be there. So what is the most likely diagnosis for this patient? After you look at his face, what do you observe in his face? So what you observe in his face are the coarse facial features. You can see the large fleshy nose, and you can see the prominent jaw, that is prognathism, deep nasolabial folds. All these are the coarse facial features commonly seen with the acromegaly, right? Even if you see the fingers are also thickened, right? So that is why the word acro means the terminal parts of the limbs and all. So acromegaly, what is the diagnosis? The most probable diagnosis here is the acromegaly. It would usually arise because of a pituitary adenoma that is resulting in the production of high amount of growth hormone. So what are the biochemical tests to confirm the diagnosis? So it is quite obvious that the patient is having high levels of growth hormone, but you cannot directly estimate growth hormone for otherwise what you will do, you will estimate the levels of insulin-like growth factor 1. Okay, it will directly correlate with the growth hormone levels. And the other test is oral glucose tolerance test. Okay, and what is the most important complication with high mortality? So the most important complication in relation to in relation to acromegaly is cardiomyopathy, right? And another one is the colon cancer, where the patient may develop the colonic polyps or carcinoma. And what are the treatment options for this condition? The treatment options, of course, the resultant disease is because of a pituitary adenoma, so you can straight away remove the tumor, right? So the first line treatment option for this condition would be to remove the tumor itself by doing a transcranial or a transsphenoidal approach, right? Transsphenoidal approach, thereby you remove the thyroid adenoma. And what are the other medical treatments, the medical therapies that are available? We have the octreotide, lanreotide, which are the somatostatin analogs, and we have pegvisomant, which is the growth hormone receptor antagonist. Okay, so the medical therapy is not the first line here. It can be used as an adjuvant therapy. Or apart from the surgical therapy and the medical therapy, we also have the radiotherapy where you can use it as the last resort, even if the patient is not responding to the other modalities. So, what are the goals of treatment and how are they monitored? Right. Soon as you give some treatment, you need to monitor the treatment course, right? So, what you will do, of course, the things that the test that you used in the diagnosis only you can use here. You can monitor the levels of IGF-1 and growth hormone levels, right? And if you want to look at the size of the pituitary macroadenoma, micro or macroadenoma, you can look at the MRI brain and monitor the size of the adenoma as well. And why is the visual field testing important here? Because the pituitary gland itself can result in bilateral superior quadrant anopia, right? And the patient will eventually develop visual field defects, and the patient can develop blindness as well. That is why the visual field testing should also be done in the monitoring. Let's move on to the next question. So, a 28-year-old woman presents with amenorrhea for the past 9 months. She denies being pregnant or using any hormonal contraceptives. She also reports having milky discharge from her breasts. Right? As soon as you find a young woman with amenorrhea, right, first rule out pregnancy. For that, you will do a urine pregnancy test. Then after that, ask the patient if the patient is using any hormonal contraceptives for this. And since the patient is also reporting of milky discharge from the breast, it is quite obvious that the patient is having high levels of prolactin, right? So the most likely diagnosis would be hyperprolactinemia. So how would you investigate and confirm the diagnosis? Of course, it is quite obvious that the patient is having high levels of prolactin, so you will directly go ahead and do serum prolactin levels. And if you want to find out if the pituitary adenoma is the cause for it, you will have to do the MRI brain as well to rule out pituitary adenoma that may be implicated in the production of prolactin. So what are the causes that can result in hyperprolactinemia? So if the drugs are implicated as the cause, what are the drugs that can result in hyperprolactinemia? They are antipsychotics, specifically typical antipsychotics, and then alpha methyl dopa, reserpine, cimetidine, amitriptyline, hypothyroidism, and other causes other than drugs are hypothyroidism, chronic liver disease, chronic kidney disease can also result in uh, hyperprolactinemia. So, what are the treatment options for this condition? So we are talking about hyperprolactinemia. We have again similar to that of acromegaly. We have three different modalities. One is the medical therapy, one is surgical therapy, and another one is radiotherapy. But in acromegaly, the first line modality is to do a transsphenoidal resection of the pituitary adenoma. Here, the medical therapy would be the best. So we'll start with the medical therapy. So in the medical therapy, we use dopamine agonists. They are cabergoline or bromocriptine. And the next, if the patient is not still responding to the medical therapy, you can go ahead with surgery, where the patient is intolerant, or if the patient is resistant, or you cannot give dopamine agonist for some contraindication, then you can go ahead with surgery. And of course, the radiotherapy is reserved as the last resort for those patients who are not responding to surgery and medical therapy. So these are the answers to the question. Now let's move on to the next question. So a 25-year-old man presents with polyuria, polydipsia and nocturia for the last 3 months. He is dehydrated and has a blood pressure of 90 by 60 millimeters of mercury and a pulse of 110 per minute. So the blood tests are shown below. What do you understand from this? The patient is passing large volumes of urine. The patient is having increased thirst as well, right? And because of dehydration, the patient's blood pressure is low, right? And the pulse is high. So the patient is dehydrated. And what do you find from the blood investigations? The serum osmolarity is high, the urine osmolarity is low, and the serum sodium is high, right? So as soon as you find the polyuria, polydipsia, and nocturia, what are the differential diagnoses that you should consider? You will consider the diabetes insipidus, diabetes mellitus, and the psychogenic polydipsia, right? So these are some common differential diagnoses that you should consider. So most likely diagnosis would be the diabetes insipidus. So what is happening here? If we simply understand, so let's suppose our body's plasma is a solution which is containing solutes as well as the solvent. So the solutes, suppose here is the salt, and we have the water here as the solvent, and from the plasma some amount of volume is lost in the form of urine. How is the urine here? The urine is having low urine osmolality. It means the patient is passing dilute urine where the salts are low and the volume is high. It means that the patient is passing away lots of water, right? So that is the reason for dehydration here. And since the water is lost, what will happen to the body water? The body water is reduced and the salt is relatively increased. That is why the patient is having the high serum osmolality, right? All this picture appears when this process of passage of low osmolar urine is facilitated by reduction in the antidiuretic hormone levels, right? So this low ADH level is seen in diabetes insipidus. So we have seen the differential diagnosis. And how do you confirm the diagnosis of this condition? So you do a 24-hour urine volume, right? If the urine volume is more than 40 ml per kg and the the serum urine osmolality is less than 300 milliosmoles per liter, then it is diabetes insipidus, right? Here the diagnosis is diabetes insipidus. Now look at the ADH levels, or basal plasma arginine vasopressin levels. If it is more than 1 picogram per ml, it means that the levels are okay, but the vasopressin is not able to act on the kidney. That is why the patient is known to have nephrogenic diabetes insipidus. But if the levels are less than 1 picogram per ml, it means the vasopressin levels are deficient, and hence the probable cause could be at the level of pituitary gland. So look at the brain MRI and look at the pituitary bright spot. If it is absent, then it is pituitary diabetes insipidus, and if it is still present, then the patient is probably having a primary polydipsia. Right. So the last question is, how do you treat the patient? So you will, if the patient is having central diabetes insipidus, you will give vasopressin analog, which is nothing but the desmopressin. If the patient is having nephrogenic diabetes insipidus, the treatment would be to give the thiazide diuretics or amiloride with low salt diet and indomethacin. Right. These are the drugs that are to be used in the management of the nephrogenic diabetes insipidus. So what I showed you is the one which is given in the recent textbooks, but this was the previous indirect way of estimation, because previously we were not estimating the AVP levels. So water deprivation and the desmopressin test, what we used to do previously, now we are looking at the plasma AVP levels, right? Previously the assays for estimation of the vasopressin were not good, that is why we were not doing it. Now let's move on to the next question. A 30-year-old woman has a history of rheumatoid arthritis and has been taking prednisolone and DMARDs for the past year. She came to OPD with complaints of weight gain. Just by looking at the image itself, you will be able to make out the diagnosis. You can see the purple striae here as well, and you can see the moon-shaped face, right? So what would be the most likely diagnosis for this patient? What did you say? Would you say Cushing's syndrome or Cushing's disease? You can clearly see in the question that the patient is taking prednisolone here. So the Cushing's syndrome, Cushing's syndrome is a syndrome where there is increased levels of cortisol, right? When the Cushing's syndrome is because of the pituitary adenoma or a pituitary cause, we call it Cushing's disease. So here the patient is having Cushing's syndrome, but it is because of the drugs, so we can call it the exogenous Cushing's syndrome or iatrogenic Cushing's. So that is the most likely diagnosis here. And how would you manage this patient's condition? How would you manage this patient's condition? So this Cushing's syndrome is because of the drug. That is why you can firstly taper the dose of glucocorticoids to the lowest effective dose, or you can switch to any other anti-inflammatory drug if possible, right? Gradually taper the dose of corticosteroid. Possibly you can remove the steroid by replacing it with any other anti-inflammatory drug, right? And while tapering, also look for the adrenal insufficiency, because the secondary adrenal insufficiency after the withdrawal of seizure is also quite common. Then what are the other complications of the drug implicated in this patient? So the drug is nothing but prednisolone. So the patient will have all the other features of Cushing's syndrome. So what are the other features? Osteoporosis, hypertension, proximal myopathy, diabetes mellitus, cataract, anxiety, depression, and increased coagulability or hypercoagulability that may result in deep venous thrombosis. So these are the possible complications of prolonged usage of corticosteroid. So these are the answers. Now let's move on to the next question. So a 32-year-old woman presents with weight gain and purple striae over the abdomen. Of course, the word itself clinches you the diagnosis here. She has no comorbidity. What do you see here? You will see you can see the bull's neck. And what is the most likely diagnosis for this patient? So the patient is having no comorbid illness and the patient is not using any drugs. So the diagnosis is still, we don't have the evidence that the patient is having Cushing's disease. We can still only say that the patient is having Cushing's syndrome, right? How would you evaluate this patient? What are the possible complications? So again, what are the possible complications here? So the possible complications would be the same that like we discussed in the previous slide: the osteoporosis, proximal myopathy, diabetes mellitus, osteonecrosis that can result in the hip fractures, susceptibility to infections because of this anti-inflammatory activity and immunosuppression, right? Depression, anxiety, psychosis, and sometimes cognitive impairment. So these are some possible complications. And what are the main treatment options? We will discuss this after we look at the evaluation part. So pardon me if the slide is quite small. I mean, the letters are quite small. So what are the steps in the diagnosis of Cushing's syndrome? We have the first step to confirm the diagnosis of Cushing's syndrome. And the second step would be to find the cause for it or the differential diagnosis. The first step would be to look at to get the levels of cortisol in the blood. We have different kinds of estimation of cortisol in the body. So the methods are, we can estimate the 24-hour urine-free cortisol or the midnight salivary cortisol, or you can do the overnight dexamethasone test, right? If it is not yet confirming, you can finally do the low-dose dexamethasone suppression test. So these tests will confirm the diagnosis of Cushing syndrome, and to find out the differential diagnosis, you will do the plasma ACTH levels. If the ACTH is more than 15 picogram per ml, then it is ACTH dependent Cushing's. For still confirmation of the pituitary adenoma, you will do the MRI pituitary and the CRH test. But if the ACTH levels are less than 5 picogram per ml, you can label it as ACTH dependent Cushing's. It means that the adrenal gland is not dependent on the ACTH, and the adrenal gland itself is autonomous in the production of cortisol. That's why you will do a CT abdomen and find out if there is any abnormality with the adrenal gland. If there can be adrenal adenoma or carcinoma or bilateral adrenal hyperplasia. Okay, you can treat them accordingly. So how do you treat this patient? So if the patient is having bilateral adrenal hyperplasia, you can do the bilateral adrenalectomy, or if there is an adrenal adenoma or adrenal mass, you can do unilateral adrenalectomy after ruling out the carcinoma, right? And these are the surgical options. If it is ACTH dependent Cushing's, then you can treat the pituitary cause as well by doing the transvenous resection. Medical therapy. What will you use for the medical therapy? You can see here: ketoconazole, metarapone, metotane, etomidate, paseriotide, cabergoline, mifepristone. These are the drugs that can be used in the medical management of Cushing's syndrome. So let's move on to the next question. A 35-year-old woman presents to the emergency department with severe abdominal pain, nausea, vomiting, and hypotension. She has a history of chronic fatigue, weight loss, and hyperpigmentation of the skin. She is not taking any medications. On examination, she is pale, dehydrated, and has a blood pressure of 80 by 50 millimeters of mercury. So, nausea, vomiting, hypotension with severe abdominal pain, and the patient is also complaining of chronic fatigue and weight loss, and the patient is even having hyperpigmentation, right? All these features, the picture fits in the diagnosis of adrenal insufficiency, right? Adrenal insufficiency. And the hyperpigmentation will also tell us that the patient is having high levels of ACTH here. And ACTH will also have the melanocyte stimulating activity, and high levels of ACTH is seen in the primary adrenal insufficiency. What is primary adrenal insufficiency? You call it as Addison's disease, right? Where the patient is, the adrenal glands are defective. That is why, because of the feedback mechanism, the ACTH levels are high. So what is the most likely diagnosis? The most likely diagnosis will be the primary adrenal insufficiency, that is Addison's disease. But you see the patient is pale, dehydrated, and the patient is having hypotension, and the patient may develop shock as well. The patient is in adrenal crisis, or you can also call it as acute adrenal insufficiency, right? So this is a case of Addison's disease or primary adrenal insufficiency. The patient is in adrenal crisis. So what are the possible causes of this condition? So the possible causes for the primary adrenal insufficiency are the autoimmune destruction of the adrenal gland. You can call it adrenalitis, or some infections like tuberculosis, HIV, and fungal infections, or some hemorrhage or tumors of the adrenal gland can also result in the Addison's disease. So what are the main hormones that are deficient here? Of course, this is adrenal failure. Obviously, the patient will have a reduction in the cortisol and aldosterone, right? So what are the expected laboratory results from this patient? So if you look at the routine laboratory investigations, what will you find? Because there is aldosterone reduction, aldosterone, the action of the aldosterone is to reabsorb sodium and excrete potassium. That is why the patient will have low sodium and increased potassium. So the patient will have hyponatremia, hypercalcemia, and because the cortisol levels are also reduced, the patient will have hypoglycemia, and because of this dehydration and all, the patient can have increased levels of creatinine and blood urine nitrogen. The patient can have metabolic acidosis as well. These are some common laboratory investigations that are seen in this patient, but the specific investigations in relation to this disease is the ACTH levels are high, right? And if you look at the plasma cortisol level, that is low. Okay, we'll usually not estimate the cortisol level alone, but what will you do? The plasma cortisol level will be fluctuating, right? So to prevent these fluctuations, you will do firstly, you will give the synthetic ACTH, or you can also call it as cosentropin. So after you give some cosentropin stimulation, then you estimate the plasma cortisol level. So these are the two specific investigations that you do here. And what is the most appropriate treatment for this patient? So the most appropriate treatment would be to supplement, right? So initially the patient is having uh, low sodium and the patient is dehydrated. So the patient is having low water as well. First give the sodium and water in this patient. So firstly give IV fluids. Hydrate the patient first, and you can after that supplement the patient with hormones which are already deficient. So the patient is deficient in cortisol. Instead of cortisol, you can give hydrocortisone. So if the patient is in adrenal crisis, firstly give 100 milligrams of hydrocortisone bolus. Then you can give 200 milligrams in 24 hours, right? And you can also supplement the patient with fluorocortisone if required. Of course, the aldosterone is also deficient here. So for aldosterone, you will give the fluorocortisone supplementation at a dose of 100 to 150 microgram per day, right? So this is about the management of Addison's disease. These are the answers here. And again, in the diagnosis as well, we have two steps. The first step will be to confirm the diagnosis, and the second step would be to find out the differential diagnosis. Like in case of cortisol, the first investigation here is the plasma cortisol after the cosentropin, and the differential diagnosis. For that, you will have to estimate the plasma ACTH, plasma renin, and serum aldosterone. See if the primary adrenal insufficiency, where the adrenal gland is not able to produce the cortisol, right? So the cortisol is reduced, the aldosterone is reduced. So by feedback mechanism, the renin is high, and by feedback mechanism here the ACTH is high. So if the ACTH level is high and the renin is high, it will probably go towards the primary adrenal insufficiency. But in secondary adrenal insufficiency, what will you find? You will find the low normal ACTH or the normal renin and normal aldosterone. So a 35-year-old woman with a history of Cushing syndrome underwent bilateral adrenalectomy 5 years ago, and she presents with the progressive skin hyperpigmentation, headaches, and visual disturbances. What is the most likely diagnosis for this patient? How do you confirm the diagnosis? So you can see the patient is having Cushing syndrome, right? For that, the patient underwent bilateral adrenalectomy. Probably the patient is having bilateral adrenal hyperplasia. So after the removal of the adrenal gland, the cortisol level will fall, right? And rarely this reduction in cortisol will result in the production of high ACTH from the pituitary gland, and sometimes rarely it can produce ACTH producing pituitary adenoma, right? So this high levels of ACTH from the pituitary adenoma is responsible for this skin hyperpigmentation. So what is the most likely diagnosis of this patient? This syndrome that is arising because of the ACTH producing pituitary adenoma is called as the Nelson syndrome. Right? This is Nelson syndrome. This is a rare manifestation that can happen. So how do you confirm the diagnosis? Of course, it is quite obvious from the understanding the patient is having high levels of ACTH. So just do the serum ACTH level, and you will also want to rule out the pituitary adenoma here. So that's why you will also do the MRI brain. So what is the pathophysiology? You just understood here. So there is loss of this negative feedback. Loss of this negative feedback would have resulted in the development of an adenoma so as to produce ACTH. So what are the possible potential complications of this condition? So what will be the complications of this pituitary adenoma that is happening here? So the patient will develop visual impairment or blindness due to the compression of the optic nerves or the chiasm, and the patient can rarely develop the pituitary failure due to the destruction of the normal pituitary tissue from the tumor, right? And the patient can also have increased risk of infections and bleeding. Low cortisol levels would have resulted in high ACTH levels after the adrenalectomy. How would you treat and prevent this condition? So obviously the patient is having pituitary adenoma. The primary modality would be to remove the tumor by the surgical approach, that is the transspinodal approach. You can also take up the radiotherapy, or you can also do the medical therapy by using some drugs which will inhibit the ACTH production. They are pasireotide, cabergoline, or ketoconazole, like we saw in the other disease. Right? Now move on to the next question. So a 55-year-old man with a history of rheumatoid arthritis is currently in a vacation, presents with a casualty with altered sensorium. He has been taking prednisone 20 milligrams daily for the past 3 months for his arthritis, but he stopped it abruptly 3 days ago because he forgot them at home. On examination, his BP is 90/60 and serum glucose is 50 milligram per deciliter. What you see here, you will see hypotension and hypoglycemia, right? The patient is having hypotension and hypoglycemia, and you can see here the patient was previously taking prednisolone 20 milligrams at such a high dose for the arthritis for the past 3 months, and he has suddenly withdrawn it, right? So the question itself is telling you the diagnosis, right? The patient is having steroid withdrawal, but the steroid withdrawal has resulted in this hypotension and hypoglycemia. That is a result of adrenal insufficiency, right? This adrenal insufficiency that is happening here is not primary, it is secondary, right? The secondary adrenal insufficiency because of steroid withdrawal. So what is the pathophysiology here? So the exogenous glucocorticoids suppress the hypothalamic axis here and reduce the production and secretion of ACTH and cortisol further, right? So when these glucocorticoids are suddenly withdrawn, the adrenal glands will not be able to respond to this increased demand for cortisol, especially during the stress, and resulting in adrenal insufficiency. So how would you confirm the diagnosis in this patient? How would you confirm? You will estimate the serum cortisol and ACTH levels, and further you will do the ACTH stimulation test. How would you treat this patient in the emergency department and after discharge? So you will give intravenous hydrocortisone, right? And you will also have to give the patient is in hypotension and hypoglycemia. So supplement the patient with dextrose if required, if the patient is in severe hypoglycemia. And probably this hydrocortisone will also increase the glucose here. And for the hypotension, you will give some IV fluids, right? And of course, resume the corticosteroid treatment, right? And if they, like in case of the primary adrenal insufficiency, the patient may also have the hyponatremia and hyperkalemia. You'll also have to correct the electrolyte abnormality here.